I want to tell you about someone. His name is Mr. Reyes. He is 64 years old, a retired construction foreman, and 3 months away from his 65th birthday. His son Miguel has been telling him for months to look into Medicare. Mr. Reyes keeps saying he will do it, or he will get to it. He worked hard his whole life, paid into the system, and figures Medicare is just the government version of the insurance he had on the job. It will kick in automatically. It can't be that complicated. Then his birthday arrived. He missed the Part B enrollment window by 8 weeks because no one told him it was not automatic. He goes to sign up and learns 2 things that could stop him cold. First, he will now pay a late enrollment penalty on his Part B premium every single month for the rest of his life. And second, Medicare does not cover dental or vision or hearing aids, and he needs all 3. He had a tooth pulled last year and held off on his glasses because he thought Medicare was coming and it would handle it. His son Miguel calls the clinic, and the clinic calls us.
Now, Mr. Reyes did not make a careless mistake. He made the mistake that millions of Americans make every year because Medicare is one of the most consequential financial and healthcare decisions an older adult will ever make, and almost no one explains it before the deadline passes.
This episode is for Mr. Reyes. It is for Miguel. It is for every nurse, NP, and healthcare entrepreneur who has a patient sitting across from them who is about to turn 65 and has no idea what is coming. We're going to break it down completely. If you're new here, welcome to the Melanin Initiative. I'm Geraldine, and I co-host the Melanin Initiative along with Kimberly and Alicia. Here, we simplify medical information into language that you can understand. We create a safe space for you to ask your questions and to share our nursing perspective. We're a health literacy podcast, and when we say health literacy, we're talking about your ability to obtain information, to understand that information, and to use that information to manage your health and advocate for others. Our mission is twofold. 1, to simplify complex health information, and 2, to elevate the expertise of nurses, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how to leverage their expertise as clinicians and entrepreneurs. If you haven't already, subscribe on Apple Podcasts or Spotify and leave us a 5-star review. Thumbs up the video, leave a comment, and share the show with your friends. This shows the algorithm that this content is important so that when people like you look for information like this, it'll show up higher in your search results. As a reminder, this show is for educational purposes only. The opinions expressed are ours alone, and they are not a representation of any of our affiliations. If you are experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. And if you're having a physical emergency, you can call 911. If you're having a mental health emergency or know someone who is, you can call 988 or text 741-741.
Now, this episode is a follow-up to our topic on medical billing. If you haven't already, we invite you to subscribe there. And it's airing in May because we're recognizing Older Adult Awareness Month. Today, we're going to use this moment to have a conversation that the healthcare system rarely initiates with the people who need it most, including those of us who work within the system. Now, let's start with the numbers, because according to the U.S. Census Bureau, approximately 10,000 Americans turn 65 every single day. By 2030, all baby boomers will be 65 or older, meaning 1 in every 5 Americans will be at retirement age. Medicare is the federal health insurance program that serves this population. And as of 2024, it covers approximately 67 million Americans, including people 65 and older, and certain individuals under 65 with qualifying disabilities or end-stage renal disease. Now, despite its reach, Medicare literacy is remarkably low. A Kaiser Family Foundation survey found that a majority of Medicare beneficiaries could not correctly identify basic features of their own coverage. Now, a significant portion did not know what their Part B premium was, what their deductible covered, or that Medicare does not include routine dental visits, vision, or hearing, as mentioned. This is not a failure of intelligence. It is a failure of education because most of us are not taught health literacy at home, in school, or even at work, even in that nursing and medical school, just like we're not taught financial literacy, but yet we're given a lot of responsibility to manage both of those things when we go home. And we have real consequences, both financially and when it comes to our health.
And unfortunately, those consequences are not distributed equally.
That's correct, Alicia. We know that Black and Latino older adults are more likely to rely on Medicare as their sole source of coverage, less likely to have employer-sponsored supplemental insurance, and more likely to delay enrolling in supplemental plans due to the costs. This leaves them more exposed to those out-of-pocket expenses, which actually get increase the older we get. Older adults for whom English is not a first language face significant barriers navigating Medicare's enrollment portals, plan comparison tools, and appeals processes, which are not uniformly available in languages other than English. The great thing is, though, now with tools like AI, you can really translate anything. Veterans navigating a parallel system, if you didn't know that, because a lot of people are afraid of AI, there's a lot of great things about AI, and there are some things you have to be cautious about, but that is one way you could use it to help you navigate the system and prepare for your next visit. Now, speaking of navigating the systems, for our veterans, they have TRICARE for life and VA healthcare that intersects with Medicare in ways that are frequently misunderstood, even by the veterans themselves. Now, our deaf and blind older adults face accessibility barriers in Medicare's primary communication channels, including paper notices, online portals, and phone-based customer services that they have a difficulty accessing. Our LGBTQIA+ older adults, particularly those in same-sex partnerships, have historically faced coverage gaps and spousal benefit inequities that have only partially been addressed by federal policy changes. This is a place where nurses can actually play a big role as an ally. And for older adults in long-term care facilities or receiving home-based care, which is becoming more and more popular, not only amongst the public, but also amongst NPs starting their own businesses, the question of what Medicare actually covers and for how long is one of the most misunderstood and financially devastating gaps in the entire program.
So we're going to walk through all of this today. By the time this episode is over, you will understand that what Medicare is, what each part covers, what it does not cover, how TRICARE intersects for veterans, and what your options are when Medicare is not enough.
So Medicare is divided into parts, and understanding what each part covers is foundational to everything else. Let's start with the original Medicare, Parts A and B. Now, Medicare Part A is hospital insurance. It covers the inpatient hospital stays, care in that skilled nursing facility following a qualified hospital stay. Just because you go to the hospital doesn't mean it's going to meet the qualification for that coverage. Hospice care, and then some home health services. For most people, Part A is premium fee is premium free, meaning you do not pay a monthly premium. If you or your spouse paid Medicare taxes for at least 10 years while working, you did not meet that threshold. You can still purchase Part A, but it will cost you a monthly premium at that time. What Part A does not do is cover everything else that happens inside the hospital. This is a deductible. There is a deductible. In 2024, that was $1,632 per benefit period, not per year. A benefit period begins the day you are admitted and ends when you have been out of the hospital or that skilled facility for 60 consecutive days. Consecutive is key. Mm-hmm. If you are readmitted after the 60-day window and a new benefit period begins and a new deductible applies.
That distinction matters enormously for older adults managing chronic conditions who are in and out of the hospital. It is not one deductible for the year. It can be multiple deductibles in the same calendar year if the hospitalizations are separated by more than 60 days. Mr. Reyes did not know that. Most people do not know until they get a bill.
Yes, which we talked about in our medical billing episode. If you haven't already, please go and watch that one. So now we go into Medicare Part B. This is your medical insurance. It covers outpatient services. This is your doctor visits and PPA, preventative services, lab tests, durable medical equipment. Maybe you have a bedside commode that's going home with you, mental health services, and some home health services. Part B has a standard monthly premium. In 2024, that premium was $174.70 per month for most beneficiaries, though higher income individuals may pay through what is called the IRMA, the Income Related Monthly Adjustment Amount. Now, Part B also has an annual deductible, $240 in 2024, and after that deductible is met, Medicare will pay 80% of the approved services. You have to know what is approved. The beneficiary is responsible for the remaining 20% with no out-of-pocket cap. That uncapped 20% coinsurance is one of the most significant financial exposures in original Medicare and the primary reason supplemental coverage exists.
So let me make that concrete. If you have a hospital stay that costs $50,000, which is not unusual for a serious illness or surgery, 20% of that is $10,000 coming out of your pocket with no cap. For an older adult on a fixed income, that number can be financially catastrophic. This is why we talk about Medigap and supplemental coverage, and we will get there. For our nurses and nurse practitioners, when your patients are approaching 65, this is a conversation you are positioned to initiate. You do not need to be a Medicare expert to say, have you looked into your enrollment window and what your coverage will and will not include? That question alone can prevent the situation Mr. Reyes found himself in. For our NP entrepreneurs, understanding Medicare billing, assignment, and reimbursement is directly relevant to your practice revenue. If you see Medicare patients and you are not enrolled as a Medicare provider, you cannot bill for their care. Enrollment timelines matter, and credentialing gaps have real financial consequences for your practice.
I also want to add for our nurses, this is also really important to get to know your case management and your social work colleagues, as they're also going to be having these conversations with your patients as far as their insurance and what will qualify on this day and what won't qualify on this day. And you would be surprised how much that matters in the hospital as far as like what we're going to do for that patient or do for you based on what their insurance will or won't cover. It really is remarkable how insurance drives healthcare. So our takeaway for this particular section is that Part A covers the hospital and Part B covers the doctor or provider. Together, they are original Medicare, and together they still leave a significant gap. The 20% coinsurance with no cap is not a small exposure. It is the reason every Medicare beneficiary needs to understand their supplemental options before they need them.
So once you understand original Medicare, Parts A and B, you can understand the two additions that build on that foundation, which is Part C and D. Medicare Part C is what most people know as Medicare Advantage. It is an alternative way to receive your Medicare benefits through a private insurance company that has contracted with Medicare. Medicare Advantage plans must cover everything original Medicare covers, Parts A and B, but they are allowed to add benefits that original Medicare does not cover, including dental, vision, hearing, and in some cases, fitness benefits and transportation to medical appointments. In exchange for those additional benefits, Medicare Advantage plans typically operate like a HMO or PPO, meaning you have a network of providers, and in many cases, you need a referral to see a specialist. This is a significant structural difference from original Medicare, which allows you to see any provider who accepts Medicare without a referral.
And this is where the trade-off lives. Medicare Advantage plans often look more attractive on paper. They have lower premiums, extra benefits, simple card. But if your providers are not in network, or if you need a specialist your plan requires a referral for, the access you thought you may have had, the access you thought you had may not be the access you actually have. So for older adults managing multiple chronic conditions, which is the majority of Medicare beneficiaries, network restrictions can create real barriers to continuity of care. Your cardiologist, your heart doctor, your endocrinologist, your primary care provider all need to be on the same network for a Medicare Advantage plan to work seamlessly. And that is not always the case, particularly in rural areas or underserved communities where provider networks are thin.
Medicare Part D is prescription drug coverage. It is offered through private insurance plans that contract with Medicare, and it is an optional but critically important add-on. Part D plans vary significantly which drugs they cover, what tier those drugs are placed on, and what you pay at the pharmacy. The formulary, that's the list of covered drugs, is specific to each plan, and it changes every year. Now, what most people do not know about Part B is that if you are eligible for Medicare and you do not enroll in Part D, as in dog, when you first become eligible and you go 63 or more consecutive days without credible prescription drug coverage, you will pay a late enrollment penalty permanently added to your monthly premium. Every month you were without coverage. Like the Part B late penalty Mr. Reyes faced, this is a lifelong surcharge for a decision that most people don't know that they were making. That's why it's critically important that you share this episode with at least one person and ask them to do the same thing.
For our older adults managing multiple medications, which again is most Medicare beneficiaries, the Part D coverage gap, historically called the donut hole, is something to understand. The Inflation Reduction Act of 2022 made significant changes to Part D, including capping out-of-pocket drug costs for Medicare beneficiaries at $2,000 per year beginning in 2025. This is a major protection for older adults with high prescription drug costs, and many beneficiaries do not yet know it exists. For patients for whom English is not a first language, Medicare plan comparison tools, formulary lookups, and enrollment portals are available in multiple languages at Medicare.gov. If your patient or family member needs support navigating these tools, state health insurance assistant programs called SHIPs offer free, unbiased counseling in many languages. The number for your state's SHIP is available at shiphelp.org. For our LGBTQIA plus older adults, Medicare coverage for same-sex spouses has been federally protected since the Supreme Court's Obergefell decision in 2015, but implementation gaps and discriminatory treatment and plan administration remain documented concerns. If you experience coverage denial or discriminatory treatment related to your identity or partnership status, you can file a complaint with the Office for Civil Rights at HHS.
And Part C gives you, our takeaway for this is that Part C gives you Medicare through a private plan with extra benefits and network restrictions. Part D covers your prescriptions, and skipping it has a permanent financial penalty. You should have this at all your birthday parties when you turn 60. Hey, let's sit and chat about insurance. And set your calendar. Part D covers your prescriptions. Skipping it has permanent financial penalty. Compare plans annually. Your medications, your providers, your budget should all drive that decision. Medicare.gov has a plan finder tool. Use it every open enrollment period. Like I said, this month we're celebrating Older Adult Awareness Month. Each episode, you're going to see some helpful images on the screen that we want you to screenshot and take with you to your next appointment, share with your loved ones. And also this month, we aired our interview with Gigabit Grandma and Grandpa. They were specifically designed by Patrick Williams to help older adults understand and decrease your fear around the use of AI tools. Particularly in that episode, I talked to Gigabit Grandma and Grandpa about how you can use them to prepare for your next visit. Not only that, after you've gone to those visits and your daughter from Texas calls you while you're living in Virginia and says, "How was that appointment?" You can actually answer all her questions when she wants to know, what are the numbers and when are you supposed to go back?
So we have covered what Medicare covers. Now we need to talk about what it does not cover and the populations for whom those gaps are most consequential. Let's start with veterans. Veterans who are eligible for TRICARE, which is the military health insurance program, and who are eligible for Medicare face a specific coverage coordination question that is frequently misunderstood. TRICARE for Life is the supplemental coverage available to Medicare eligible military retirees and their dependents. It works alongside Medicare. Medicare pays first as the primary payer, and TRICARE for Life pays second, covering most of the cost sharing that original Medicare leaves behind, including that uncapped 20% coinsurance. For veterans with TRICARE for Life, Medigap coverage is generally not necessary because TRICARE for Life already functions as a comprehensive supplement. However, TRICARE for Life requires that you are enrolled in both Medicare Part A and Medicare Part B. If a veteran delays Part B enrollment, perhaps because they still have employer coverage or because they did not understand the requirement, they lose TRICARE for Life until they enroll in Part B. And they may face the late enrollment penalty in the process.
Thank you, Geraldine. I don't think a lot of people know that. My own father is a veteran and has TRICARE for Life, and both my parents have Medicare Part A and B because they have to be a part of TRICARE for Life. But I don't know. We never talked about this. I always wondered, where they get this information from? Who told them to do that? Where'd they get this knowledge from? So this is a situation we see in our communities. Veterans who serve this country, who have earned their TRICARE benefit, who lose access to it because of an enrollment timing issue nobody explained to them. This is a health literacy failure with real consequences for a population that has already given everything.
Those were great questions. Shout out to my mom, because I know she's going to watch and answer your question in the comments. And so we know this is a lot of information. We don't try to act like it's not. And that's why you can come back and watch the replay. If you're listening on the podcast, we want you to watch us on YouTube so you can get those screenshots. And that's why we're just going over it. We don't expect you to remember everything. That's why we encourage you to write things down, bring an advocate with you, and use tools like AI so that you can be better prepared, less stress, and actually get the care that you need. Now, for our veterans who receive care through the VA system directly, so not through TRICARE, the coordination is going to be different. So the VA, healthcare, and Medicare operate independently. Having Medicare does not affect your VA benefits, and having VA benefits does not replace Medicare. They cover different things in different settings. A veteran receiving care at a VA facility uses their VA benefits. That makes sense, right? A veteran receiving care at a non-VA hospital or provider uses Medicare. Understanding which system to use and when is a navigation challenge that many veterans face without adequate support. And many of our veterans don't like to ask for help because they're used to being the help. This is something we see every day. Now, talk about long-term care, because this is where the most dangerous Medicare myth lives. Most people believe that Medicare covers nursing home care. It does not in the way that you're thinking. Medicare A covers skilled nursing facility care only following that qualified hospital stay of at least 3 days, only for care that is considered skilled, meaning it requires the services of a licensed nurse, LVN, LPN, RN, or therapist, and only for, so that's physical therapy, occupational therapy, speech, and only for a limited time. For the first 20 days, you get 20 days, Medicare covers the full cost. From day 21 to 100, there is a daily co-insurance, $204 per day in 2024. After you pass day 100, and a lot of people do, I know it's not going to happen to you, but it happens to a lot of people, Medicare stops paying. The patient or their family is responsible for the full cost of care.
Wow. And the average cost of a private room in a nursing home in the United States in 2024 was over $100,000 per year. Medicare does not cover that. Medicaid does, but only after a beneficiary has spent down nearly all of their assets to qualify. This is the financial reality that devastates families who did not plan for it, and it disproportionately affects Black and Latino older adults who are less likely to have had access to long-term care insurance or generational wealth to absorb those costs. Long-term care insurance is a private product that covers custodial care, help with activities of daily living like bathing, dressing, and eating, that Medicare explicitly excludes. It is significantly less expensive when purchased at a younger age. For our NP entrepreneurs who serve older adult patients, adding long-term care planning conversations to your patient education touchpoints is a genuine act of advocacy. And I'm planning on adding it now that I'm learning so much about Medicare, just kind of thinking about it before we get to that point. It's very, very important, just thinking of like finances in retirement.
I was going to say, and both of you could probably attest, I would say that this topic of long-term care benefits, Kimberly's going to talk about home health care, people going to skilled nursing facilities. These are the number one things that keep patients in the hospital a long time. We've gotten you in the hospital. We've treated you what we're going to do for you in the hospital. And then in our attempt to get you to a safe discharge plan, which could be going to a skilled nursing facility, maybe you need long-term care, maybe you do need that home health. There's often an insurance barrier there to get you to that next step, whether it be your insurance covers it, but maybe insurance denied it because it wasn't under the approved list. So now we have to figure out what's next for you. Is it going to be an out-of-pocket payment that maybe you or your family wasn't expecting? So now we have to wait for you to sell that car, sell that home, those things that you were not anticipating when you came to the hospital that day before we can send you to that skilled nursing facility. So these are real things that we see every day. And when I mean every day, I mean every day. There are multiple patients, I'd say, on any hospital, in any given unit that is there strictly because we are navigating insurance of getting them out of the hospital to their next space in a safe environment, simply because insurance, or figuring out how we're going to help you or how you're going to help you pay for it.
Yeah, and it's very sad. You have to sell everything.
Everything.
That's your home. And if we're talking only about our older adults who experience a lot more death, You might be the last surviving person in your family. Your kids might be scattered. Your grown children might be scattered across the country. They might be still working full time too. Maybe they're providing for you. Someone has to make money still, so maybe they're not available. It's devastating. And like Alicia said, at any given time, I'm going to go out here and get some groceries. My life can suddenly change. I never make it back to my home. So there's depression, there's anxiety, there's fear, there's PTSD, then there's your physical. What brought you to the hospital, right? Maybe you're not walking anymore. You're like the people I was just complaining about who I work with who are smoking. My brother who's high blood pressure, he has yet to do anything about. You're going to be that patient who's young and having a stroke, and you can't use half your body, and you need help. Men, this is for you. You will need help at some point in your life. You're not invincible. And when that happens, you don't want to be alone. I tell my brother, you don't have to get married, but you need to have someone who's going to care for you. You do, because we're strangers. Look, I love my patients and I want to give them the best care, but at the end of the day, I don't know them. You need someone there who knows you. They think our information is the most important. I tell them, no, your information is the most valuable. I'm making decisions about their problem. You need to make decisions about the person. Totally different, totally different. You can see we can go on this all day, but it's just so sad because people aren't expecting it. And it's a real shift. And it really does it makes everyone really vulnerable at that time. Because now and you could be so far away from home, especially here in the country of Texas. People are far away from home. And that's devastating. And whether it's children, their loved one is also sick. They can't see them. They die. They have a funeral and they haven't seen them for months. And maybe you speak that other language. You were the breadwinner. You're even more depressed because you're letting the whole family down. We see this every day.
Or you live in Texas and you're trying to make healthcare decisions for the uncle that lives in DC, and you're like, I don't even know what that skilled nursing facility looks like, but I'm gonna have to just trust that you all are putting them in a space that's good for them and their environment and their learning situation. It's very interesting and challenging. It can be very challenging to navigate.
And people will say, everyone's gonna die, and maybe they're like my mom who just told me she wants to die in her sleep. Right? When's the last time you saw a patient die in their sleep? I've never seen a death certificate that said they died in their sleep. So death is a long, drawn out process because we have great medicine and we have wonderful procedures that can prolong your life. So that suffering that you're dealing with, it can literally be decades. And so you're in this facility with people that you don't know who are stressed out. You see all the other episodes we talk about, we're stressed, right? And you're depending on us to care for you. And the thing is, this is what I think about. I say, okay, everyone's going to need help. But the decisions you make for yourself, you think you're only hurting yourself. But if you recognize that you're going to need help, you're either making that help going to be easy on someone, or you're going to make that help be really difficult based on the decisions that you make every day. And that person is a nurse. So I'm very passionate about that, right? This is someone who's 20 years old. They just graduated. They're 120 pounds. You're 350. You can't move. You can't feed yourself. You're incontinent all the time. Check out our incontinence episode. The help is struggling because you couldn't stop smoking. You drank every night. You ate out every day. And now you need somebody's help. And you're wondering why they can't turn your loved one, why they're getting all these problems, why no one answers your call bell, because they're helping all these people. And everyone's so sick. And because the country's so sick and they didn't listen to Alicia and stop smoking, go to their primary care provider, they wait till the last second. Now they're in the emergency department. So everyone in the hospital is really, really sick. And they're going to the ICU. The ICU is full. They need to make a bed. So they say, who's the least sick of the sickest? It doesn't mean they don't still need ICU care, but we just need your bed. So they move them down. But that patient still needs that one-on-one supervision. And those people, we got to move one of them out too. So they're still really sick, but they got to go. So now they're in that long-term care facility. And those nurses, those LVNs and those LPNs are doing the best they can with very limited resources. We're talking limited. That's real business right there. Of the healthcare system. If you haven't been attuned to the business side of healthcare yet, you're going to see it there. It's slim. It's tough. It's tough. Okay, so home healthcare, which I'm a big proponent of. I want everyone to age at home. I want you to die at home if that's your choice. And if you're starting a business, Think about the home. Now, home health care is related but a distinct category. Medicare does cover home services, but only under specific conditions. The patient must be homebound, meaning leaving home requires considerable effort. The care must be ordered by a physician or qualified practitioner, and the care must be skilled. That's requiring a nurse or therapy services. What would you need a nurse for? Help with medication, wound care, cleaning up, moving, any sort of decision that's not, even outside of getting dressed, bathing, getting out of bed, which you need to get out of bed. Anything that requires that is going to cost money. And even the therapy, right? If you have that stroke and you can't swallow, you need someone who can manage that safety risk. Now, custodial home care, this is a home health aide helping with bathing and meals without skilled nursing involvement. Anyone can do this job. If you're looking for a job, there's millions of older adults who could use your help. It's not covered by Medicare. For older adults who want to age at home, which is becoming more popular, which research consistently shows is the preference of an overwhelming majority. The gap between what Medicare covers and what home-based aging actually requires is significant. Medicare does not cover some home and community-based services through waiver programs, but eligibility, availability, and scope do vary by state. It does cover.
Yes, that's another thing that holds a lot of people up in the hospital is getting these home health aides arranged and who's going to pay for it. And a lot of times, as Kimberly just stated, it's an out-of-pocket cost, and insurance may cover, but they may only cover 1 hour out of the 24. And you're like, how is my loved one going to get what they need if we only get 1 hour of coverage in the whole day? So those other 23 hours are out-of-pocket services. And that could have financially devastating consequences. So for the caregivers in our audience, the daughters, sons, spouses, and community members who are doing the daily work of supporting an older adult, this gap falls on you in real and exhausting ways. Understanding what Medicare covers and what it does not is the first step to planning ahead rather than being blindsided. You cannot pour from an empty cup, and you cannot plan for something nobody told you was coming. For our deaf and blind older adults and their caregivers, home health agencies are required to provide accessible communication. If an agency cannot communicate effectively with a deaf or blind patient or cannot provide materials in accessible formats, you can request a different provider or file a complaint with your state's home health licensing agency.
So our takeaway here is that Medicare does not cover long-term custodial care. It does not cover a nursing home stay beyond 100 days. It does not cover home aides who are not providing skilled care. These are not small gaps. They are the gaps that exhaust family caregivers and deplete generational wealth. Plan before you need it. Have the conversation before the crisis.
Oh, and can I interject? Some of those skilled services could be maybe getting home dialysis, IV therapy, antibiotics, fluids, tube feeds. Those kind of things would be. And then I want to say, if you want to decrease your chance of needing any of this, when you're at the hospital, we need you to get out of the bed. That is the number one thing, is not getting out of the bed your whole stay. So now that whole time you stayed in the bed, you lost your muscle strength. So now when it's time to say get discharged, the thing you've been waiting for, you can't go home because you have to build your strength back. So I tell everyone, the worst position you can be in is laying on your back. Literally any other position is the best position, but there's no perfect position. That's why you have to reposition every couple hours. Yep. And so when your loved one's there, take advantage of it. Help sit up, walk around the unit, just do as much as you can. Do it during meal times. You get lost with the times, but they're going to bring that tray 3 times a day. Use that as your reminder to get out of the bed, sit in the chair, put your legs up, anything.
Know the signs of a stroke, because the faster you act, the more of the brain you save. Use the word FAST. F for face. Ask the person to smile. Is one side drooping? A for arms. Ask them to raise both arms. Does one drift down? S, speech. Ask them to repeat a simple phrase. Is their speech slurred or strange? T, time. If you see any of these signs, call 911 immediately. Do not drive yourself. Do not wait to see if it gets better. Time is brain. Every minute counts. Other signs of stroke include a sudden severe headache with no known cause, sudden vision changes in one or both eyes, sudden confusion, and sudden loss of balance or coordination. Stroke can happen at any age. Black Americans experience stroke at nearly twice the rate of white Americans and are more likely to die from it. Know the signs Share them with your family. Put FAST in your phone right now so you never have to remember it in an emergency. If you or someone near you is showing signs of a stroke, call 911. Not in 5 minutes, but now. This message is brought to you by the Melanin Initiative Podcast, where we simplify health information so you can advocate for yourself and the people you love. Find us on Apple and Spotify. So before we bring Mr. Reyes back, here are your action items. If you are an older adult or caregiver, mark your 65th birthday on your calendar and count back 7 months. That is your initial enrollment. That is when your initial enrollment period begins. Do not miss it. Go to Medicare.gov and use the plan finder to compare Part D and Medicare Advantage plans based on your specific medications and providers. If you need help, call your state's SHIP at shiphelp.org. It is free, it is unbiased, and counselors are available in multiple languages. If you are a nurse or a nurse practitioner, every patient approaching 65 needs a Medicare readiness conversation. You do not have to be a Medicare expert. You need to know the enrollment window, the late penalty consequences, and the long-term care coverage gap well enough to raise the flag to refer to a SHIP counselor. That conversation is within your scope and it matters. If you are a healthcare entrepreneur and cosmetic NP, if any portion of your patient population is Medicare eligible, you need to be enrolled as a Medicare provider, and you need to understand assignment and billing requirements. If you are seeing veterans, understand the basic structure of TRICARE for Life so you can answer the questions your patients will ask. And if you are building a practice that serves older adults, long-term care coordination and home health referral pathways are value-added services that distinguish a comprehensive practice.
Yeah, and we know, shout out to Jay Trevino, the Mahogany Dermatology Nurse Fellow of 2025. She's a nurse and she started her own business. Nurses are starting businesses. You don't have to go back to NP school to start a business. You can do it right now because that provider only has 10 minutes to talk to the patient. That patient has 60 minutes worth of questions. Your business can help address that gap. That's what, when we talk to you about functional medicine, that's why Dr. Latea Jesus, she could physically treat patients in West Virginia, but she could see patients across the whole country because for those patients, she wasn't writing prescriptions. That's what nurses don't write prescriptions, but you can answer questions. You can sit on the phone for a long time. You can help coordinate care. So that's a business that, and if you address older adults, I say if you address older adults and nurses, you have a customer for life. Now let's go back. And if you involve tech, like the first thing when my dad, he fell, I wanted to see in that home. I wanted cameras. If you start involving technology in your business, you're really set up for life. You have AI, you can create an app. It's so easy right now. You just need the time. So you can't keep packing your schedule. That full-time job, that PRN job, the clinical instructor over there, your friend has a job. So sometimes she asks you to help. You have to have time on your schedule because this is all great information. But when the job tires you out or burns you out, the last thing you want to do is come home and look up anything. So the information is there, but you have to create the space to be able to take advantage of it. Let's go back to Mr. Reyes. After Miguel called the clinic, a nurse there walked the family through Medicare.gov. They founded their state SHIP program. And because Mr. Reyes was more comfortable in Spanish, they asked specifically for a Spanish-speaking counselor. One was available within the week. The counselor walked Mr. Reyes and Miguel through 4 things. First, because Mr. Reyes was still within a limited window, they submitted a special enrollment period request to CMS. This is the Center for Medicare Services, Medicare, Medicaid. Documenting the circumstances. The late penalty was not eliminated, but it was reduced. You don't ask, you won't get it. Second, they compared Part D plans based on Mr. Reyes' actual medications and found a plan that covered all of them at a lower tier than the default plan he had been about to select. Third, they identified a Medicare Advantage plan in his area that included dental and vision benefits. 2 things we all need, but especially as we get older,
right,
which addressed 2 of his 3 coverage gaps. Fourth, they had a conversation about long-term care that Mr. Reyes had never had before. His wife is 2 years younger than him. If he needs extended care before she does, the financial exposure without a plan is real, and that conversation is ongoing. He still paid a penalty. That didn't go away, but he went from being completely unprotected to having a coverage structure that made sense for his health, his budget, and his family, who at the end of the day is going to be the ones making decisions for him.
And nobody in Mr. Reyes' life ever sat down and explained Medicare to him. Not his employer, not his provider, not the government that sent him a card in the mail. A nurse of the clinic and a Spanish-speaking ship counselor changed the trajectory of his retirement healthcare in one conversation. That's all it takes.
Right. That is what health literacy looks like. It is not a pamphlet. It is not a portal. It is a person who speaks your language, literally and figuratively, sitting with you and helping you understand what you are entitled to before the window closes.
Today, we covered Medicare Parts A, B, C, and D. I don't know about you ladies, but I can never get enough of this conversation. We covered TRICARE for Life and how it intersects with Medicare for our veterans. We covered the long-term care coverage gap and what Medicare does and does not pay for in skilled nursing and home health settings. We covered enrollment windows, those late penalties, and the Part D drug cap. And my favorite really was the SHIP program. All resources referenced today will be in the description box, and then we're going to have something for you to screenshot here that will help you take your first step after watching this episode. And my favorite, of course, was showing what it means to be a nurse.
If this episode gave you something, share it. Someone in your circle has a parent or grandparent approaching 65 who does not know what they do not know. Send them this episode before the window closes. Find us on Apple Podcasts and Spotify. Leave us a review and tell us what topics you want us to cover next. This podcast exists because of this community. And if you're a nurse practitioner who wants to go deeper on the business and clinical side of healthcare entrepreneurship, visit Mahogany Dermatology Nursing and the Alliance of Cosmetic Nurse Practitioners. Links will be in the description box. If you found this information helpful, check out our episodes on medical billing. We are the Melanin Initiative. Until next time, take care of yourselves and take care of each other. See you next time.